Okay, so impaired fertility. We used to call it infertility, but that's not really an accurate word anymore because infertility means that you are not able to be fertile. But a lot of times it's just impaired fertility where with a little bit of assistance, maybe you can be fertile. Um, what we're looking at is how many menstrual cycles it took before you became pregnant. And for, you know, 20% of the population, they get pregnant in their first menstrual cycle, the first time that they're trying, or the first time that they went without birth control by accident or whatever. For 30%, it takes 2 cycles. 40%, and of course this is cumulative. So when we say 40%, they got pregnant by their third menstrual cycle or faster. So you see the numbers going up until we get up to 92% of people will become pregnant within 13 menstrual cycles of trying or not using any birth control. So what we're left with is this 8% who are in the impaired fertility category. So what causes impaired fertility? About 40% of the time it's something with the male, about 40% of the time it's something with the female, and about 20% of the time it's something that that maybe together they're sharing. It might, had I had a different partner, maybe I wouldn't be struggling with this kind of situation. So what are the causes of male infertility? Well, you'll notice that 34% of the time it's unexplained. So that's a little bit unsatisfying when, a third of the time there's no way to figure out what's wrong. Then you see all these other things. Undescended testicles. So the testicles are up in the abdominal cavity, and so remember the testicles need to be outside so that the sperm can be produced in a cooler temperature than body temperature. So undescended testicles are treatable by, basically a type of surgery where the testicles are brought down into the scrotum, and a lot of times that fixes the problem. Urogenital infection is referring to having had pelvic inflammatory disease, and so maybe there's some scarring of the tubes. Sexual factors where they're not functioning correctly, and so they're not ejaculating sperm into the reproductive tract. Systemic diseases. I always have trouble with this. Whoops, I just clicked something wrong there. Sorry. I always have trouble pronouncing that word. It's varicosely. I think I said it right. Whew! I think I said it right. Blood flow problems. Hypogonadism is where they're not producing enough testosterone. Immune system factors, where they're attacking their own sperm. And then there are other causes that have been identified, so it's not in the unexplained category, but it's like, happens to very few people, so we just sort of lumped them all together. Females, for some reason the pie chart was drawn differently for the females, even though I got it from the same source. We have a smaller number and then you'll notice they didn't give us percentages, but you see a smaller number that are unexplained. And then, sorry about that noise. And then you see like all these different anomalies, congenital anomalies, things that happened in the womb while the woman was developing as a baby herself. So things that she are sort of misformed. You've got acquired factors like something that has happened that's now since she's been born, that's now making her reproductive tract not work correctly, or her hormone levels be out of balance or something like that. Urogenital infection, so she's got some kind of pelvic inflammatory disease going on. Immunological factors, just like males. Tubal damage. Ovulatory failure, so she's not releasing an egg. Endometriosis, we talked about that being a common cause of infertility before. Anomalies of the uterus, maybe she doesn't build up the lining correctly, or she's missing a lining, or things like that. Endocrine disturbances, which means a systemic, her whole body, her hormones are off. So there are all these different possible causes. I like this chart though that really emphasizes that it's half the time it's going to be attributable to the male and half the time attributable to the female, and then the remaining times it's both. Because a lot of times we focus in on the female first. We're like, oh, you can't have kids. And sometimes it's no, together we can't have kids. We're in that 20%. Like it's something about us together, or you know what? It's just as likely to be his fault as mine, right? And that's funny because a lot of times I always like to ask my students in class this question: when there is, difficulty conceiving in a couple, who is most likely to go to the doctor first to find out if if they've got something going on? And it doesn't even take a second for the students to go, well, the woman usually, right? And what's funny about that is that the women go first, is that to find out what it could be for a woman, there are all these things that need to be done to rule out this and rule out that and start honing in on what it really is. So first off, we have to have a general physical exam. There are all these blood tests to check for hormone levels and different things. We have to check out the ovarian reserve, which means that we might have to go in with a laparoscopic camera and actually go and look to make sure that the ovaries have eggs in them. We might be able to do it with ultrasound. We have to check for ovulation, which we can do through a blood test and look for hormonal fluctuations, but we also want to make sure that an actual egg is being released, even though we know the hormones are there, an egg might not be being released. So we might do, again, a laparoscopic or an ultrasound. We have to check for whether the tubes are clear. That's what tubal patency means. So we have to, again, we could put a camera through that or maybe an ultrasound. I'm not sure. We might have to inject stuff in you to make the ultrasound actually show the tubes correctly. Got to make sure that the uterine cavity is clear and building up endometrial layers. And then we might, again, need a laparoscope to check to see whether there's any scarring in the uterus or the tubes, or whether there's any endometriosis present. For males, a physical exam, some blood tests, and then he needs to ejaculate in a cup so they can analyze the semen. Make sure the sperm are healthy, that the nutritive stuff that's supposed to be present from the prostate and all that stuff is present. And it's really interesting how often it is the woman who goes and gets checked first. And after all this stuff's been done, then the man's like, well, maybe it's me. And still he may not want to go. And it's really a sign of, like the worries about, virility that go along with fertility, that, for men, it's tied up with masculinity. For women, it's like they still take it, women take it pretty hard when they are worried that they are not going to be able to have children if they want to. But it isn't necessarily quite the same, like fear of not being really a woman in the way that it is for men. Both sexes have similar concerns, but for men, it seems like they'd rather not have to go get the checkout because they figure it can't possibly be me. When I ejaculate, stuff comes out. I'm working fine. And they oftentimes don't want to find out that maybe they've got low testosterone or something like that. Nobody wants to find these things out, let's be honest. But men seem particularly reticent. The good news is we've got a lot of treatments available for fertility problems. That's kind of a good news, bad news thing, because one of the most common causes of impaired fertility is age for both sexes. As you get over the age of 30, it is dramatic how fertility declines. Everybody always thinks it's, especially for women, but it's actually for both sexes. It is more pronounced for women. It's like a sharper cliff for women, but men's fertility declines with age also. And so it's kind of a good news that we've got treatments for fertility problems because, if you want to have a baby, it's nice to be able to have a baby, right? But one of the downsides is that we think as young people, well, I'll get all my eggs in a row. I'll have my career in place. I'll have my education done. I'll have my first house bought. I'll have all this stuff that I want to have done. I want to be out of debt, which is funny. I want all this stuff to happen first, and then I'll be ready to have kids. And by the time all that stuff happens, you're 45 years old, and then in that, impaired fertility category. And so it's kind of good news, bad news that we have a lot of treatments available. So we've got the least invasive ovulation induction, which is taking hormones to trigger ovulation, follicle monitoring, which is usually done through ultrasound, and then timing intercourse carefully to make sure that you're delivering sperm to the vagina in a timely fashion so the sperm has time to swim up to what will be less than 24 hours old egg. right? So it needs to all be planned out and get it together. But this is like the least invasive, a little bit of hormone addition, and then some follicle monitoring. A little bit more invasive, we're going to do the first two things, right? Ovulation induction and follicle monitoring. And then we're going to inject the sperm up into the uterus so it doesn't have to swim as far. So this would be used if the concern is like sperm motility. Maybe it doesn't swim that well. And then the most invasive is to do one of the various different ways of in vitro fertilization. Your textbook talks about a lot of different ways that this can be done, but the basic premise is that a sperm is injected into an egg, or an egg is put in a petri dish and a bunch of sperms put on top of it, and they penetrate themselves. But the idea is it's done outside the body. The fertilization occurs outside the body, and then the fertilized egg is implanted. And again, there are a lot of different places where it might be implanted, typically into the uterus, but depending on what kind of IVF you're doing, it gets implanted into the fallopian tube or into the uterus or whatever. So we have got treatments available. Now, the more invasive, the more expensive, right? So if, of course, the cheapest way to get pregnant is the old-fashioned way, right? The next expense level would be, ovulation induction and follicle monitoring, and then following up with the old-fashioned way, timed intercourse. It's going to cost more if you're going to have the sperm delivered to the uterus, and then way, like thousands, tens of thousands of dollars to do IVF. And, people who do IVF, depending on age, the older you are, the less successful it tends to be. But depending on age, you're looking at, maybe a 50% chance of actually having the IVF be successful, and it's really, really expensive. So I always like to encourage my students who, I tend to have 18 to 22-year-old students in class, and I always like to encourage, delaying reproduction until everything in your life is perfect may lead to an inability to reproduce. So it's just something to keep in mind, that starting it seriously at age 30, the likelihood declines. And if you're not buying that, you can check it out. Google fertility changes, and you'll discover after age 30 it really declines for both sexes. All right, well, that was my little cautionary tale, so I will see you guys in chapter 10.